Hi, my name's Dr. Schnorr. I'm one of the reproductive endocrinologists at Coastal Fertility Specialist, and I'm glad you're here today. What I wanted to spend a couple minutes with you to talk about is preimplantation genetic screening. You're thinking about undergoing in vitro fertilization care, and there's a new way that we can actually test the embryos to determine which are the best embryos so that we put the best embryos back into the uterus, and that's called preimplantation genetic screening. It's actually a way that we can actually biopsy the embryos, study the cells that are in the embryos to make sure that the cells are normal chromosomally before the embryo is transferred. And that has some advantages and some disadvantages. And most importantly, I want you to be an informed patient, that you know what the options are, that you know what the pros and the cons are, and make the decision which is right for you. So sit back, relax, and we'll be done in about 10 to 15 minutes. The process of in vitro fertilization has a couple of steps. The first step is to give you medications to help you make eggs. The second step is to take the eggs out and fertilize them. The third step is now to grow the embryos in an incubator. And the last step is to transfer the embryos back into the uterus. There's another video that I've created titled In Vitro Fertilization, which goes over the details of each of these steps. What I'm going to do is spend just a short amount of time just kind of reorient you to the process, and then we'll talk about the preimplantation genetic screening steps. The process of in vitro fertilization actually first starts with medications to kind of slow your ovary down so that we get the ovary to stop and reset itself before we put you on injectable medications. Those medications that slow the ovary down can be birth control pills, sometimes Lupron, and sometimes we use a different medication called ganirelix. We then start the ovarian stimulation with a process called Follistim. There's also a competing product called Gonal-F, which are equally good, and those are the medications which can be used to help you make multiple eggs within your ovaries. We use ultrasounds, estrogen levels, and progesterone levels to help understand how your body's responding and when the egg retrieval needs to be done. Once the eggs are finished being made, we'll have you come to the main office in Mount Pleasant where you'll meet with a nurse anesthetist who will put an IV in your arm. We'll talk about the procedure and then give you medicine so that it drifts you off to sleep. And while you're asleep, an ultrasound probe is put into the vagina. A needle's guided along the side of the ultrasound probe through the side of the vagina and into the ovary to retrieve the eggs. The retrieved eggs are then handed to our wonderful embryology team, who then works behind the scenes to fertilize the eggs and develop embryos and then grow the embryos out under a microscope. It's important to kind of think about what the team is really doing in the background. Unfortunately, we don't know, or nobody in the field knows, what medicines or fluids or hormones to put onto the eggs or embryos to make them stronger or better. Really, the goal of an embryology lab is to mimic the uterus and provide an environment that's the same as the uterus so that the embryos, which are then growing in the incubators, can reach their maximum developmental potential in the incubators. And during that period of time, we can select which are your best embryos that later should be put back into the uterus. Of all embryos created, about 25% will give you a chance of pregnancy, and 75% will not give you a chance of pregnancy. And so our job is to make sure that we're putting the right embryos back into the uterus. If the wrong embryos are put into the uterus, it increases your risk for a negative pregnancy test, and it increases your risk for a miscarriage. So that's really the process that's happening behind the scenes. I'm very proud of Dr. O'Leary and Jennifer Martin and Delphine Dorr and the whole Coastal Fertility Embryology team for putting together an incredible lab which has done a great job in helping to provide that background environment that needs to be identical to what the uterus is really doing. The process actually starts with the eggs being retrieved and put into isolettes. This is a picture of an isolette in front of you. It's a plastic kind of protected environment that has a microscope built into it. That environment inside the isolette has body temperature levels, body humidity levels, body oxygen levels, and we use the same fluid that's in your body so that the embryos, when they're actually in the isolette and in the incubators, are in a protected environment that's the same as the uterus. And this is that's an extra step that most labs don't do. And this means that whenever your eggs and embryos are out of the incubators and being looked at under a microscope or being worked on, they're always in the uterus environment, which is different. A lot of labs actually do that in room air, which is not the same as the uterus and can harm the embryos even while they're being looked at under a microscope. One of the first decisions we have once we retrieve the eggs is how we're going to fertilize the eggs. One option is just to take the sperm and put the sperm on the outside of the egg and let the egg fertilize itself on its own. We call that standard insemination. Another option and newer technique is called intracytoplasmic sperm injection, also known as ICSI. ICSI is typically done for male factor infertility. But if you choose to have genetic testing done of your embryos, there's a significant advantage to having ICSI done in those particular cycles. And the reason is that in some cases of fertilization, more than one sperm can fertilize an egg, and that can make it so that the DNA detection is harder with preimplantation genetic screening. So for those reasons, if you choose to have genetic testing done of your embryos, regardless of if you have male factor infertility or not, the recommendation is that we actually put a needle directly into the egg, deposit a sperm into the egg, and then remove the needle at the end, which is manual fertilization. It's important to know this is a procedure which has now been done in our field for well over 20 years. There appears to be no increased risk of birth defects from the procedure itself. If ICSI is done because the sperm count is very low, there does appear to be a very slight increased risk of chromosomal abnormalities in the resultant embryos, a very slight increased risk. But we think that's due to the sperm in those cases being chromosomally abnormal, which is why there's such severe male factor infertility. It's not a procedure related impact. If you actually have ICSI done for severe male factor infertility, it's thought there's about a 3 to 4% chance of having a child with a birth defect. That compares to the risk of having a child with a birth defect without ICSI, which is probably 2 to 3%. And if you have a child on your own, also probably about a 2 to 3% chance of a birth defect. So if ICSI is done for severe male factor infertility, a very slight increased risk of a birth defect. Once the eggs are fertilized, they're then put into incubators. We use some very new special incubators, and those incubators are incubators that have a smaller chamber inside of them. And in that chamber is where the embryos are put, where the embryos are then always kept at body temperature, body humidity levels, body oxygen levels, with the same fluid that's in your body that's now in our incubators. The unique thing about these incubators is that with a really small chamber, if you open the door, the gases and temperature get back to the normal temperatures that are appropriate for the uterus within minutes versus other incubators which have larger doors and larger chambers and can often take hours to get back to normal. So that in our environment, rarely is the embryo out of the normal uterine environment, and almost all the time is it in that normal uterine environment. As I mentioned early on in this video and in prior videos, the goal of the lab is to now figure out of your embryos which are the embryos that are normal and should be put back into the uterus. Typically, we have 5, 7, 10 embryos that are available to choose from, and embryos about 25% of the time are viable and will give you a chance of pregnancy. So out of your 10 embryos, we'd expect maybe 2 to 3 are going to be normal. And so what we would recommend doing is one option is just putting the embryos in the incubator and watching them grow and develop with time. This is the first day of embryo growth. You can see that the chromosomes have formed in the center, showing that the male and female chromosomes are coming together to form a fetus. On day 2 of embryo growth, an embryo grows from 1 cell to 2 cells, and later on the evening of day number 2 grows into a 4-cell embryo, and we can look under a microscope and count the number of cells and measure the embryo size. On day 3 of embryo growth, we again reassess the embryos, and we look and we count the number of cells an embryo has. An embryo typically that's really doing well has about 8 cells on day number 3, and this is typically a time when we actually decide whether or not to do a transfer. And the goal is to look at all the embryos you have and determine, can we find your 2 or 3 best embryos, and if we can, then we would typically do that transfer on day 3 of embryo growth. If we can't determine which your best embryos are, we then grow them to day number 5 of embryo growth, which is called the blastocyst stage of embryo growth, when embryos have now grown from approximately 8 cells, which is what they were on day number 3, to approximately 150 cells now. Now, these are 4 beautiful blastocyst embryos that you can see in front of you. You can see that the embryos are large in size and have a good architectural pattern. And studies would show that these embryos will give you a good chance of pregnancy. But interestingly, if we were to biopsy the embryos, we would find that the embryos that you see in front of you right now, which are just the best looking embryos, probably 60% of the time are chromosomally normal and 40% of the time they're chromosomally abnormal, which is why these types of embryos don't always give you a pregnancy. By looking with a regular microscope, we can count the number of cells and architectural pattern, but what we can't tell is how many chromosomes are in each of the embryos. These are metabolically active, growing embryos. They just are not necessarily chromosomally normal embryos. Once we have good quality embryos and they're put back into the uterus, the chance of pregnancy depends on the quality of the embryo, the chromosomal normacy of the embryo, and it depends on the uterus being receptive. So why doesn't IVF always work? It's for some of those reasons. You know, a common question I would have is I made an embryo and I had it put back in the uterus. Why didn't it work? Well, the most common reasons are that the embryo looked normal and was growing normal, so it was metabolically normal, but it was chromosomally abnormal. And if an embryo is chromosomally abnormal, your body doesn't want you to have an abnormal baby and therefore makes it so that embryo does not continue to grow, or if it does continue to grow, has a much higher chance of miscarriage. The second reason that you cannot conceive, even if you had a normal embryo, is that the uterus might not be receptive at the time. What are things that make the uterus so it's not receptive? Well, actually, the IVF stimulation, which results in higher estrogen levels, sometimes can over thicken the inside of the uterus, and by over thickening the inside of the uterus, lower the chance that an embryo can grow into the uterus, even if it is normal. For in vitro fertilization to work, you need a metabolically viable embryo which is growing and has the appropriate number of cells, and that we can assess under a microscope. But the chromosomes need to be normal, and human beings have 22 pairs of regular chromosomes, and then they have, in addition, 2 sex chromosomes, which are either going to be 2 X's or an X and a Y. And we also need a receptive uterus. And the new technology allows us to biopsy those embryos which are viable growing embryos and test those embryos to see if the chromosomes are normal before they're put back into the uterus. It also has a solution to make sure that your uterus is receptive. The technology of preimplantation genetic screening allows us now to combine a bunch of new technologies which are coming together at the same time. Number one, newer technologies allow us to count all 24 chromosomes at one time, when in the recent past we couldn't really count any more than 5. The second is it gives us a much higher degree of accuracy, and there's less embryo harm because the biopsy is now being done on day 5 of embryo growth and sometimes day 6 of embryo growth rather than what used to be day 3 of embryo growth. And this is now being coupled with a newer freezing technology that allows us to freeze the embryos once the biopsy is done, so that while we are waiting for a determination of the chromosome status, we can let your uterus recover from the higher estrogen level, and that then allows us to transfer the embryos back into the uterus at a time when your estrogen levels in the normal range, making the uterus more receptive. The embryo biopsies now are being done on day 5 or day 6 of embryo growth. This is a picture of a blastocyst embryo on the right-hand side, in which you see a little holding pipette holding it in place on the left-hand side of the picture, a beautiful round blastocyst embryo, and on the right-hand side is the biopsy pipette. And what you're seeing happen is you're seeing the pipette pull 2 to 3 cells from the placenta out of the embryo so that those cells can be studied to make sure that they have the appropriate number of chromosomes. That study takes probably 3 to 4 days to get results back typically, and the embryos need to be looking for the uterus around that same time. So we would typically biopsy the embryos on day 5 or day 6 of embryo growth and then freeze the embryos so that they can be used on a later date for a good chance of helping you conceive. Question would be, does the embryo biopsies cause harm? And based upon the latest studies, there appears to be very little, if any, harm done from the embryo biopsies. Second common question is, are we biopsying the nose cells or the ear cells? And there's two important messages along those lines. Number one is that an embryo at this time is what we call totipotent, which means that any cell can become any part of the body. So if you take away two cells and they were the cells that might otherwise become the nose or the ear, other cells would pick up and perform that growth and division insofar there isn't any problems from the biopsy. The second thing is when we do these biopsies, we're almost always pulling out just the placental tissue, 2 to 3 cells of the placental tissue, rather than of the embryo itself. The challenges associated with IVF and preimplantation genetic diagnosis are that the embryos are looking for the uterus around day number 5 or day number 6 of embryo growth to implant. If you hold them out any longer, they will not grow in the uterus. And so that's problem number one. The second problem is that there's what we call a window of implantation for the uterus, a certain finite period of time that that embryo is allowed to grow into the uterus. And if we miss that window of implantation, you won't conceive. And by doing embryo biopsies with the delayed time for the results can sometimes make it so that the window of implantation is closing. And as I mentioned earlier in this video, sometimes the high estrogen levels in an IVF cycle can decrease uterine receptivity, which is the ability of an embryo to grow into the uterus. And so the solution is that we have the new ability to freeze embryos in a very special way. The embryos are then frozen for 2 to 3 weeks. And then once we have genetic testing results back and your uterus recovers from the higher estrogen level, we can then thaw one embryo at a time and put that embryo back into the uterus. That newer freezing process is actually called vitrification. It's a process we used originally for freezing eggs, as we saw it was very helpful for freezing eggs, and it's now being applied to embryos with a high degree of success. And essentially what you can see in the top left-hand corner, slides A and B, are the vials that embryos are ultimately frozen in. In slide C, in picture C, you can see this little loop, which is under a microscope here in D. And in this little loop, we can actually put embryos onto the loop, onto a little film, and then plunge the embryos, as you can see in E, in the liquid nitrogen to freeze the embryos. This is done after we do some dehydrating of the embryos and some other things. And then once the embryos are frozen, they have a very high chance of survival and a high chance of pregnancy when you're ready to use them. You can use them a day later, you can use them a year later, and you can use them 10 years later with no decreased chance of pregnancy or increased chance of birth defects from the freezing process. That once the embryos are frozen, all metabolic processes in the embryo are stopped and you have a great chance of pregnancy. What does the typical freezing cycle look like, the process look like when you're now ready to use your frozen embryos? Well, we generally do it immediately after you do your IVF cycle. So after your egg retrieval, about 10 to 14 days later, you'll have your period. And then once you have your period, around that time, the biopsy results are returning. So we know how many of the embryos were normal versus abnormal. And I'll call you and go over that with you. We'll then wait for your body to ovulate, or another option is to put you on low dose hormones that gives your estrogen back to the normal level. And then we generally thaw one of the normal embryos and put one of the normal embryos back into the uterus. And there are many benefits to preimplantation genetic screening that we're just beginning to understand. And in that prior slide, you might have been surprised that I said we would just put one embryo back into the uterus. But the reason that we would just put one embryo back into the uterus is that a one embryo transfer, if it's a metabolically normal embryo that's growing well and looks good under a microscope and is now demonstrated to be chromosomally normal, gives the same pregnancy rate as if we had done a two embryo transfer. So there's no need to put in more than one embryo into the uterus. Now, a lot of people would say, well, what if you do want a multiple pregnancy? Maybe we could put two embryos back into the uterus. We could put two embryos back into the uterus, but remember they're already frozen, so there's no harm in keeping one in the freezer and putting it in at a different date. And number two, multiple pregnancies have significant harm. The harm to a multiple pregnancy is that we as human beings were built for one baby at a time, not two or three. And so having more than one baby into the uterus makes it so you have an increased risk of mom's complications such as preterm labor, preterm delivery, preeclampsia, miscarriage, birth defects, variety of abnormalities that can occur from the pregnancy. There's an increased risk of fetal harm with all that, where the baby is born prematurely and has cerebral palsy and other problems. And so we very much value a one baby pregnancy and think that a two baby pregnancy is certainly good, but not as good as having one baby at a time. So we as reproductive endocrinologists want you to have as many children as you want to have. We just want to space your children out by year or 2 years apart. And that gives you as a parent a little bit of a chance to enjoy the one baby at a time. And it's a little bit easier to raise one baby at a time than it is two at a time. We also know with the biopsies that the embryo is chromosomally normal, and the most common cause of miscarriage is a chromosomally abnormal embryo that's growing in the uterus. So if we've done the biopsy, we now know from multiple studies that the miscarriage rate is lower. Miscarriage is, of course, a very emotional time period, but one in which procedures frequently need to be done, like a DNC, and there's costs and time delays and other problems with that. The biopsies significantly lower the chance of miscarriage. As you can imagine, the biopsies also lower your chance of having a baby with a numerical chromosomal abnormality. The biopsies aren't foolproof, as you'll see in the next slide. There is a slight error rate with them, but if your biopsy is normal of your embryo, it would be very unlikely for you to have a baby with the abnormal number of chromosomes, like Down syndrome, Turner syndrome, other things. I want to make a real specific point here to let you know that this lowers the chance of chromosomal abnormalities, but it does not detect all causes of birth defects. There are many birth defects that are not genetic chromosomal number abnormalities, such as autism and developmental delay and potentially having an extra toe on your foot. Those are generally not chromosomal abnormalities that biopsies would be able to find. Well, you're going to find that preimplantation genetic screening is a little bit more expensive up front. It probably saves a lot of money in the long run because you're not spending money to use embryos that might otherwise be abnormal that we don't know are abnormal. For example, you might have some embryos that look just beautiful under a microscope that we freeze for you. If we didn't biopsy them, we'd know that about 40% of those embryos would be abnormal, and you would be spending money to use chromosomally abnormal embryos that would never give you a chance of pregnancy. Having biopsied them in the past would make it so that we don't use those embryos, and that saves you money in the long run. As with any medical procedure, there's benefits and risks to the procedure, and it's only fair that I go over the risks with you. The risks are, number one, is there's an increased cost up front. You'll find that preimplantation genetic screening is probably about an additional $4,000, some of which might be covered by your insurance carrier. I think that there's some benefits in the long run cost-wise to doing the procedure, as we talked about in the prior slide. There's an error rate that they're going to actually be looking at 3 cells and trying to study the number of chromosomes in a cell, which is a very small amount of DNA. It's amazing the technology even exists and works. And it works amazingly with about a 95% accuracy rate. There's a 5% chance that they're going to say an embryo is normal when it's really abnormal, which is actually a low risk, but it's a real risk. And there's a chance that a normal embryo is called abnormal about 5% of the time by the technology. Theoretically, there could be some harm to the embryo from doing the biopsy. Lots of biopsy pregnancies have now been studied, and there does not appear to be any increased risk or harm, but future studies could show that, and we'd have to wait and see how the studies show up over time. There's possibly harm from embryo freezing. We think 90% of frozen embryos will survive the freezing process and 10% won't, and so that's a risk to the process. And interestingly, there may not be any embryos available for transfer. That's really technically a risk. That would mean that you produce 10 eggs or 5 eggs or whatever the number is, and of the embryos that were created, every single one of them was chromosomally abnormal. Some would consider that a risk that you wouldn't have any embryos for transfer. Frankly, I think this is a benefit to the technology. It lets us know not to waste your money on the transfer. It lets us know why the pregnancy wasn't going to work or why you weren't going to get pregnant, and allows us to retool and regroup so that we can find ways of making things better in the future. Frequently without biopsies, you put embryos in the uterus, you don't know why it didn't work, and this would have explained that those would have been abnormal embryos and gives us ways to monitor and improve things in the future. Well, that's the end of our video today. I appreciate you spending time to listen to it. Why did I create this video? Well, I created this video because providing high quality patient care is very important to me. and I'm hopeful that the video gives you some information about preimplantation genetic screening that you didn't know otherwise. And so my goal is always to make sure you're fully informed about your diagnosis, your treatment options, and your treatment course, and that's what this is about. It's not a substitute for talking about it in person. If you have any questions, whatever, please feel free to give me a call. I'd be happy to go over that. I personally believe that preimplantation genetic screening is revolutionizing what we do in IVF. There's no doubt in my mind, 5 or 10 years from now, we're going to look back and think, can you believe we put embryos back into the uterus and we didn't know if they were genetically normal or not? I think we're going to look back and think that was just a crazy thing to do, when the reality was that's just what the technology was at the time. But now, with a variety of different technologies coming together, biopsies on day 5 instead of day 3, the ability to do microarray testing to test all the chromosomes instead of just 5 like we did in the past, the ability to vitrify the embryos, that new way of freezing, all this coming together has made it so that preimplantation genetic screening may be the right thing for you, and I want to make sure it's presented to you. If you have any questions, feel free to call us. Our phone number is 843-883-5800. Hope you have a great day. Bye-bye.